Hey everybody, John Garner. I'm the Director of Electrophysiology for the CoxHealth system, which means I'm a cardiologist and an electrician. I'm here today with a very mixed audience. We have Special Forces soldiers and we have paramedics, as well as anybody else who cares to join us out there on the internet. Today we are going to be going at lightning speed through a huge array of cardiology topics. We're going to take a break here and there, so there will be time to get up, take care of anything that you need to do. And any questions, please hit the chat over there, and we will do our best to try and get to it. I guess let's go ahead and begin, guys, whenever we're ready. All righty. Okay, looks like we are up and running. All right, the first thing to know about the cardiovascular system, three primary components that make this thing work. You've got a pump, a tank, and some pipes, okay? So when we're talking about the pump, we're talking about the heart. When we're talking about the tank, we're talking about the reservoir of blood in the body. And when we're talking about the pipes, we're talking about the veins, the arteries, and the capillaries that connect veins to arteries. Now, the pump itself comprises a redundant system. It's really two separate hearts. There's a right heart and a left heart. Each heart has an atrium that then goes to the ventricle of that heart. The right heart's purpose is to receive blood back from the body and then send that blood off to the lungs to be oxygenated. That is the sole purpose of the right heart. The left heart is noticeably bigger than the right heart, and this is because everything that isn't sending blood off to the lungs is the responsibility of the left heart. So brain perfusion, body perfusion, distal organs, this is all going to be left heart. So the left atrium receives that blood back from the pulmonary circulation, sends it off to the rest of the body via powerful contraction of that left ventricle. All right, so the pipes then become of crucial importance. This is how we're going to get everything from point A to point B. Now, the blood begins by returning through two large veins, the vena cavae to the right atrium. The superior vena cava carries somewhere between 2/3 and 3/4 of the blood, and the inferior vena cava carries the rest. This blood comes back in a deoxygenated state. In normal people, this blood comes back at about 70% saturation. It passes through the right atrium, through the tricuspid valve, out into the right ventricle, and then is ejected from the right ventricle via the pulmonic valve into the pulmonary circulation. Now, the pulmonary circulation consists of an astonishingly large network of capillaries that interface with tissue that's only 2 cells thick. And the reason that this tissue is so thin and the reason that the vessels are so numerous is we need oxygen to cross over. Anything thicker than about 6 cells thick, oxygen has an extremely difficult time crossing over. And so we need to keep a very high surface area and a very thin exchange membrane. Now, under normal circumstances, somewhere between 97 and 100% of the blood's oxygen carrying capacity is recharged by the lungs. The reason it's not always 100% is because just a little bit of blood sneaks through in what we call a shunt. Once that oxygen is picked up by the blood, it's time to go through the pulmonary veins back to the left atrium. Now we have a high saturation again. Now we're seeing sats of 97 to 100% in that left atrium. We eject that blood out to the rest of the body. Now, the most important of these pipes is called the aorta. It's the major blood vessel that comes out from the left ventricle. The blood passes through the mitral valve going from the left atrium to the left ventricle, passes out the aortic valve going from the left ventricle into the aorta itself. Okay? Now, the reason that the aorta is so fundamentally important is because it is highly elastic. Now, if you're in the gym and you're sitting here doing lifts, you don't want to just grab a 200-pound bar and just heave as hard as you can. Terrible for the joints, terrible for the muscles, gonna result in some sort of a failure, okay? That's why Olympic weightlifting requires training, right? If you're going to get that thing off the ground and throw it overhead, you have to learn how to accelerate into that motion. We do not want to ruin our heart. If we ruin our heart, we don't get a backup, okay? The heart does not get a day off. It does not get a recovery day. So nature has designed a very clever system. The heart does not pump the blood directly into the tissues. Instead, that left ventricle charges the aorta. The aorta is a powerful muscular artery, and the heart pushes all the blood into the aorta, where that energy is then stored by this elastic structure. Think of it as blowing up a balloon. That energy can be recovered later by just letting the balloon go, and that's exactly what we do. The heart stops squeezing, aortic valve snaps shut, but this aorta is still charged with blood, and it now squeezes that blood gently to all the rest of the organs over the remainder of diastole. Okay, so these pipes are extremely important. Once we leave the aorta, we branch off into arteries. From arteries, we branch into smaller things called arterioles. Arterioles. These are small muscular arteries. These have a profound ability to constrict, and the reason that that is important is because this is the level at which the body regulates the pressure to each individual organ. These arterioles can clamp down, and if you suffer an injury or if an organ is under distress, this is how it's regulated. This is also how shock is managed by the body. From the arterioles, we go to the capillaries, from the capillaries to the venules, from the venules back to the veins, and the veins are these capacitance vessels. They are designed to accept a large volume of fluid, whereas the arteries are designed to accept a large pressure of fluid, right? So your arteries are your pressure vessels, your veins are your volume vessels. They work together. The tissue takes all the pressure out in the capillary bed, and so it has to return under low pressure to the heart. Okay, very good. So now we've covered how the basic mechanics of circulation work. Let's talk about what we're filling these vessels with. We are looking at putting most of the blood through the body via the venous system. So at any given point in time, if I could just figure out where your blood is, 60 to 70% of it is going to be hanging out in your veins, all right? The remainder is in the arteries. Why this imbalance? Because again, arteries operate under high pressure, low volume, and the veins work under high volume, low pressure. Did I say that backwards? So arteries, low volume, high pressure. Veins, high volume, low pressure, okay? Now, how much blood do you have? Well, you have several liters. In most people, you're talking about 75 milliliters per kilogram, so this works out to roughly 6 to 7 liters for most normal-sized adults. Women get shortchanged both by weight and by the amount of blood contained per unit mass. We've talked about how these are distributed among the capillary networks, but this is worth going over just a little bit. You can see what the usual distribution state is of blood in this center diagram right here. So for example, the kidneys are taking 22% of your usual blood flow, the GI system another 1/5, and some structures require very, very little blood. So the heart, for example, requires only 3% of the blood in your entire body. This is particularly important because that means even a small blockage in the blood supply to the heart is a big loss of flow, right? That's why heart attacks are so easy to come by. All right. So moving into pathophysiology, shock is anything that results in insufficient matching of the oxygen delivery via the blood to the oxygen demands of the system. Okay? There are a lot of ways we can get into shock. We'll talk about those. The main categories are cardiogenic, which means the pump is the broken part. Okay? The fluid is there, the vessels are ready to carry it, the heart just isn't sufficiently motivated to charge up that aorta. Obstructive shock. This is where the heart is ready to go, the blood vessels are ready to receive it, but there is something blocking the flow of blood from the heart into that aorta. There's something that is blocking the heart from being able to eject that blood effectively. Distributive shock. This is where the heart is pumping at least a normal amount of blood, and usually even more than a normal amount of blood, but those vessels that I talked about, those resistance vessels that should be clamped down and regulating pressure, are broken because of a disease process or because of a neurologic injury. Those vessels have suddenly relaxed tremendously, and so now we have a much larger space to fill with our of blood volume. And then there's hypovolemic shock, okay? So for our soldiers out there, this is the goal for the enemy and the goal to avoid for the friendlies, right? Hypovolemic shock is simply not enough fluid in the tank, okay? That's all there is to it. Consequences of decreased perfusion are predictable. You're going to see a decrease in the amount of pressure that fluid is driven into each organ, which is going to result in an impaired oxygen exchange. And so that's going to produce a change in the way the tissue metabolizes. We're going to go from aerobic metabolism to anaerobic metabolism. We no longer have that air that we need to efficiently utilize glucose. What's going to happen? We're going to build up lactic acid. We're going to start dropping the pH first locally, then globally if we don't fix the problem. We're going to see the body attempt to react to decreased perfusion. Remember, we have those arterioles, and in everything except distributive shock, they are going to act to clamp down, to put that blood flow in places that will keep us alive, okay? The human body is not smart. We are designed to live 30 to 40 years to survive saber-toothed tiger attacks. Nature never got the idea that we would develop penicillin and live to be 90 years old and deal with congestive heart failure and McDonald's, okay? It's not something we're evolved for. So all of these reactions are designed to keep you alive the next hour, the next day, the next week. None of this is designed to keep you alive the next 30 to 40 years. And that's where we get into trouble with chronic disease states, okay? When there's not enough volume, the skin is going to clamp down. It's going to squeeze away from this non-vital organ, and it's going to focus on perfusion of the things that will keep you alive the most. So, the things we need the most, the brain, the heart, and the lungs. We're going to concentrate blood in those three locations. What are we going to sacrifice then? We're going to sacrifice the skin first. We're going to sacrifice the gut second. We're going to sacrifice the kidneys third, right? We're going to take blood away from these organs that the body deems not essential at this exact moment to keep the blood where it is essential. However, that comes with consequences. If you don't supply blood to an area of tissue, it's going to become ischemic, it's going to become necrotic, and you're going to end up with some bowel like that picture that you see right there. We're going to lose our urinary output because we're no longer feeding an effective amount of blood to the kidneys, which means we will have decreased clearance of toxins as well. So you see that in your laboratory studies. So there are two responses to this sort of a state. There's a short-term response and there is a long-term response. Short-term response is almost all neurally based, okay? This is a neuroendocrine response. So you have a whole bunch of chemicals that get secreted. The body, again, not very smart. We only have 3 sensors in the body that can tell us whether we have a problem with our perfusion, okay? One is the carotid baroreceptors. We've got a sensor just under the jawbone in each of the carotid arteries in our neck. We've got a very weak sensor in the arch of the aorta, and we have sensors in what we call the afferent arteriole of each kidney that can tell how hard blood is pushing. And again, these are not very smart sensors, okay? They don't directly measure the pressure. What they measure is the pulsatility. They measure those arteries expanding and contracting. So anything that keeps those arteries from expanding and contracting will be perceived by the body as having low blood pressure. This is where heart failure comes in, and we'll talk about that later. When these sensors detect a marked fall off in the distension of these arteries, several things happen. Direct activation of the heart occurs by neural mechanisms, and the heart is made to squeeze harder. In addition, the adrenal glands begin secreting epinephrine and norepinephrine, which cause the vasoconstrictor response that we just talked about, where the arterioles are clamping down, and also promotes additional actions by the heart to pump this blood even harder, even faster. Then we have a much delayed reaction. Following this, the kidney responds to this whole thing. So when the kidney stops fluctuating at its arteriole, the kidney begins secreting a chemical called renin. Renin then triggers angiotensin. Angiotensin then triggers aldosterone. And the purpose of all of these chemicals is twofold. Number one, squeeze those arterioles, tighten up the blood pressure. Number 2, retain salt. At all costs, we need to maintain fluid in the tank because there's one final mechanism that underlies this all, and that is the Bezold-Jarisch reflex. And when the fluid reaches catastrophically low levels, the whole system collapses as the heart walls begin banging against each other as the body tries to keep the heart from slapping itself into oblivion. We never want to get to that state. The body will always try to avoid that. Very rare to see that ever happen. Okay. Is our remote working here? There we go. Cardiogenic shock. Let's talk a little bit about this. Like we said earlier, this is the heart not squeezing efficiently and adequately to deliver that blood forward. This can come from a lot of things, but all of them have something in common, and that is that they create mechanical inefficiency in the heart. Okay? So, things that can cause this. The number one cause of cardiogenic shock is myocardial infarction, without question. Okay? If you shut off the blood flow to any portion of the heart has 3 arteries that usually supply it. If you shut off any one of those arteries, a large portion of the heart muscle is not going to be receiving its necessary blood flow. What's going to happen is the same thing as when you sleep on your arm. The heart isn't going to be able to move, okay? And sometimes even after you get the blood flow back, it takes a long time for that to wake up. Second thing that can cause this is the delayed consequence of a heart attack, which is heart failure. If you don't get the blood supply restored in an adequate amount of time, you're going to go ahead and have the tissue die off. When that tissue dies off, it becomes shoe leather. Totally useless. Does absolutely nothing for the rest of the patient's life. We don't have stem cells that can heal it yet. We have no procedure. Once a wall of your heart is fully dead, it is fully dead, and that's how it stays. But sometimes it's not even that bad. Sometimes it gets even worse than that. Sometimes, instead of just turning into a tough sheet of shoe leather, it kind of turns into a sack of saran wrap. And we call this an aneurysm. Okay, so this is where the wall is not only not contracting, it's bowing outward. Well, this is a real problem because you've got this part of the heart trying to squeeze that blood and this part of the heart that says, oh, I got it, I'll just expand. So you lose a huge portion of the mechanical efficiency of your heart with one of these aneurysms. Then there are 2 states of cardiac stunning. The first is mediated by overload of adrenaline. We call this a Takotsubo, a stress cardiomyopathy, or a broken heart syndrome. This is where the body is exposed to a profound and sudden overwhelming amount of adrenaline. The heart says, I don't know what to do with this. And it just flops out on the couch. It just says, you know what, not going to do it. Has a very characteristic shape that we can see when we squirt contrast into the heart or when we do echocardiography of the heart. The tip is typically ballooned out in about 85% of cases, but not always so. In addition, right after cardiac arrest, the heart is also stunned. Is it by the same mechanism? Nobody really knows, but a low heart squeeze right after a cardiac arrest is normal. It is the expected finding. Very rare to have somebody have a full-blown cardiac arrest and still have good heart squeeze afterward. Heart failure, we've covered a little bit. Left heart failure, overwhelmingly the most common because of this coronary artery disease and these ischemic insults from heart attacks. Kind of the dirty secret of the right ventricle is that if it makes it through a heart attack, it will almost always heal itself back. The left ventricle, not so much. Is that because of the thickness? Is it because an altered distribution of stem cells exists? Not totally clear. Right heart failure is a very important entity and an extremely important one to recognize. So for our special forces trainees out there, I want you to recognize if someone presents you a typical picture of heart failure, which is to say they have lower extremity edema, they have RAAS on their lungs, and they have an elevated jugular venous distension, that is left heart failure. But if they give you all those signs, but they have clear lungs, what they're trying to point to is failure at the right heart. You'll still get that pressure back up into the neck, you'll still get that pressure back up into the legs, but you won't back up any fluid into the lungs because the failure exists at the right heart. Think of it like a freeway, right? You know, you've got all these exits on the freeway. You've got the vena cava with its first exit being the right atrium, the second exit being the right ventricle. Wherever it is that you have the failure, the traffic's going to back up behind that. Again, if they have clear lungs, elevated JVP, lower extremity swelling, think right heart failure. If they have those wet lungs, that big JVP elevation and that leg swelling, think left heart failure. Left heart failure doesn't always present that way. Sometimes people don't store that fluid in their legs, they store it in their belly, but that's sort of the atypical variant. Most of the time you're not going to see that on tests. Alrighty, how do we treat heart failure? Well, step one is we have to reduce the amount of fluid that the heart is trying to clear. We have to decrease those pressures that are backing up into the lungs, into the neck, into the legs. And we do that with diuretics. Diuretics are medicines that cause the body to lose salt via the kidneys, and the golden rule of water is that water follows salt, okay? So we're not actually getting rid of the water directly, we're getting rid of the salt and the water follows along for the ride. In addition to that, if the patient is having difficulty breathing, sometimes we give them morphine. This is a venodilator. This causes a decrease in the pulmonary pressures and allows the patient to feel like they're breathing a little bit easier. If the heart is not squeezing adequately, we have drugs like milrinone and dobutamine that increase the squeeze of the heart and push that blood with greater force forward. And in the long term, we have to block those chemicals that we talked about. Remember, we're designed to survive a saber-toothed tiger attack, not designed to survive 30 years. All the things that I've described, the adrenaline, the renin, the angiotensin, the aldosterone, all poison to the body in the long term. We have to block those with beta blockers, with ACE inhibitors, with ARB medications, with spironolactone. We have to shut those mechanisms down so they don't damage the heart in the long term. We got a few cute animations here. Right heart failure, again, we need to decide whether this is an acute emergent situation, patient just had a heart attack or something like that, patient just had a pulmonary embolism, and in that case, we need to keep that pressure in the right heart high. We do not diurese these people. That blood is at this point flowing mostly passively through the right atrium. In an infarction, in a PE, we need that higher preload to push that blood straight through and get it through that obstruction. We do not want to significantly reduce the pressure on these people. In chronic right heart failure, where the problem is no longer an acute issue of the right heart not pumping or not being able to push its blood forward, in those situations, that's where we're going to want to use those diuretics. If the patient has a known long-standing history of pulmonary hypertension, they're fluid overloaded. What you do not want to do is excessively vasodilate these people. Giving these people nitroglycerin when they have obvious right heart failure can result in circulatory collapse, okay? You're going to decrease the venous pressures, you're going to decrease the return pressure to the right atrium and therefore the right ventricle. They're going to have less fluid to work with, and if they were already struggling in the first place, that's where they're going to get into trouble. Obstructive shock. Now this is where the heart wants to beat, but it can't. It's physically blocked from pushing that blood forward. The number one cause is pulmonary embolism. If you have a patient who has some sort of a history of long immobility in the recent past, they've been on a very long plane flight, very long car ride, they have been invalided home, can't move their legs. If anything at all has caused them to lose that ability to keep those legs moving, then think pulmonary embolism. Okay? Again, also if the patient has a history of hypercoagulable disorder, this is something important to think about. In trauma, number one cause is not PE, but is rather cardiac tamponade. Okay? Cardiac tamponade is buildup of fluid around the heart, and it's a one-way process. The fluid builds up more and more, but it has no place to go. It has no relief, and therefore it starts squeezing on the heart, compressing it down and preventing the heart from being able to fill up in the first place and therefore minimizing its ejection in the second place. Okay? When you think cardiac tamponade, number one and number two are trauma. Number 3 is severe congestive heart failure, but that doesn't usually result in tamponade. That usually just results in an effusion around the heart. And cancer. Okay, so cancer causes the lining of the heart to secrete a lot of fluid. That fluid doesn't necessarily have a constraint. All right. Now, fluid around the heart can be accommodated by the pericardium. Think of it as saran wrap. If you try to stretch it real quickly, you'll just tear it. But if you stretch it slowly, it'll stretch out, a pretty considerable amount. Heart's the same way. If you build up your fluid slowly, it takes an awful lot to cause tamponade. But if someone just put a knife through your chest, if you just took a gunshot wound, then that fluid can build up very quickly, and it only takes 200-300 milliliters of blood to completely obstruct the right ventricle. Very different process. Pulmonary embolism we talked about right here. The keys are that these patients have chest pain, they have dyspnea. Ironically, the smaller the PE, the more chest pain they have. Big, giant, massive PEs rarely accompanied by chest pain. However, those massive PEs are almost always accompanied by dyspnea. What are you going to find? You're going to find tachycardia, you're going to find hypoxemia, and the JVP is usually going to be elevated if it's sufficient to cause a major obstruction to the heart. Cardiac tamponade is best manifest by the Beck's triad. Okay, this is JVD, hypotension, and muffled heart sounds. To my special forces guys out there, you will see this material again. JVD, hypotension, muffled heart sounds, okay? When you see those 3 things, the key is the muffled heart sounds, okay? Those muffled heart sounds are quiet because there's a big layer of fluid sitting around the heart blocking the transmissions of those sound waves out to the wall, all right? Again, penetrating trauma, aortic dissection, cardiac surgery, all traumatic issues. You will sometimes see that as the patient breathes in and out, there will be a very exaggerated level of their pulse. If you have an arterial line or some sort of beat-by-beat blood pressure measurement, you'll see exaggerated variation with cardiac tamponade. That's because as they breathe in, the right heart pressure goes up, the left heart pressure goes down. As they breathe out, those switch places, the left heart pressures go up and the right heart pressures go down. All right, distributive shock. This is where the blood vessels are excessively dilated and inappropriately so. All right. For these, the number 1 cause by far is sepsis. Okay. This is manifest by direct toxins of the bacteria and by indirect mechanisms of the body. So certain bacteria, E. coli in particular, have toxins that can just cause these blood vessels to say, I don't know what I'm doing. I'm just going to take a nap. And they relax. Way too much blood pressure goes flying through the floor. Other causes, anaphylaxis, and then the rarest causes neurologic injury way up high in the cervical region where those autonomic reflexes are coming from. This can cause a big problem up there. The treatment of distributive shock is always the same initial management. You need to fill those pipes. Okay, these pipes have suddenly become much, much bigger than they should be. You have to match the amount of fluid the patient has to the size of the pipe. Fluids, 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 okay? The biggest advances in critical care over the past 30 years have all revolved around recognizing that we have been giving way too little fluids in the past to people in distributive shock, especially sepsis. All right, sepsis we talked about. Anaphylaxis, this is an autoimmune reaction mediated by the body freaking out at a substance that it is not used to seeing. It causes release of histamine, mast cells degranulate, and these blood vessels lose all intention of holding themselves together. What's the solution to this? Epinephrine. Epinephrine, epinephrine. It's not Benadryl, it's epinephrine, okay? So maintain your ABCs, airway, breathing, and circulation, and get that patient epinephrine as soon as possible, okay? In addition to that, if they have that distributive shock, make sure that you get them fluids. All right, good. And there you go, nice picture of the EpiPen. Neurogenic shock, again, almost always in the cervical regions of the spine. almost always from some sort of a traumatic event. So this is usually a fracture, a transection, a bullet passage, some sort of serious injury going on up in this region. This causes the body to lose all of its autonomic regulation, but not necessarily in one direction or the other. These people can have wild fluctuations from one side to the other. Blood pressures of 300 all the way down to a blood pressure of 50 within a 5-minute period, not uncommon. All right, very good. Okay. And hypovolemic shock, this is very simple. You don't have enough in the tank. Either you're way too dehydrated and you've sweat and breathed out all your fluid, or someone has caused you to exsanguinate. All right? The solution to this is self-evident. Replete whatever fluid is lost. If they're just dehydrated, give them saline. If they are exsanguinating, give them blood and saline. Whatever you got available is better than nothing in hypovolemic shock, okay? Alrighty, I believe that takes us to our first break. I appreciate y'all's attention. I know we went through at whirlwind pace, and I will be back with you in just a little bit. Hey, there we are. All right, perfect. Time for Cardiology 2. Once again, this is going to be a whirlwind presentation. We're collapsing what are usually 1-hour lectures into 30-minute web streams for you guys so that we can keep this as brief as possible, try to make this as high yield as possible for you. Please make sure you go back and review the material later if there's some stuff that we glossed over. I do this live for you guys every time, so I'm sure that of the many, many things we say today, at least one of them will probably be inadvertently wrong. If it is, please let us know. Get it corrected. Okay, moving on. We are talking today about heart attacks and EKGs, and I think we may have started, yeah, not necessarily on the right slide there. Okay, so let's talk about heart attacks first. We have a number of risk factors that were identified early in the 1950s as being the key factors that contribute to the risk of developing a heart attack, that being hypertension, hyperlipidemia, and smoking. Those were the three initial factors that were readily identified. They hold as true today as they did then. The thing that we've added to that list is diabetes. Diabetes is, for all intents and purposes, the development of coronary disease, even if they don't have it yet, because it's such a rapid and accelerated aging process that even people who otherwise would have had normal arteries will develop coronary disease. The same is true of dialysis. It's an exceptionally fast aging process. Almost all patients on prolonged dialysis will end up developing coronary disease, and the #1 cause of death for dialysis patients, other than direct renotoxicity, is in fact myocardial infarction, consequences of coronary disease. Okay, so when we talk about anginal symptoms, when we talk about inadequate blood flow to the heart, the things that we think of are typical angina. And what does that mean? Well, it comprises 3 key elements. #1, it is a substernal discomfort. #2, it is described as pressure-like in nature. And #3, it is onset with exertion and relieved by rest or nitroglycerin, okay? So these are sort of your typical features. Typically, if there's going to be radiation, it radiates to the left arm, usually rotates down an ulnar distribution and causes an aching sensation in that arm, sometimes radiates to the scapula, sometimes radiates to the jaw. Don't be fooled if the patient has symptoms that seem like they could be chest pain, but with radiation to the right arm. That is actually more predictive of a heart attack than the left arm is. The left arm is just more common, okay? So the characteristics that should concern you are a patient who has an onset of prolonged chest discomfort, okay? This is pain that's usually greater than 30 minutes long. Anginal pain doesn't come and go in seconds. That's not a thing, okay? If you're going to block the blood flow to the heart, it's like sleeping on your arm. Your arm doesn't just go numb for a second. Once it stops losing its blood flow, it's going to take a minute or two to get back. So you're going to have at least several minutes of discomfort, okay? It's not like you'll have a patient who says, oh yeah, I started walking and I got some real bad chest discomfort and then I just sat down in a chair and it went away immediately. No, that may be something, but that's not angina. The story you want to hear there is, I sat down in the chair and the pain gradually faded over 5 to 10 minutes. minutes, something like that, okay? Anginal equivalents are important to know about. Not all symptoms are classic, and they become less likely in diabetics, they become less likely in women, and for these you have to know sort of the anginal equivalent type symptoms. So epigastric discomfort, number one missed cause of myocardial infarctions in an emergency department. We don't want to miss that. Patient complains of epigastric discomfort, probably a reasonable thing to go ahead and throw an EKG on them, make sure you're not missing a big STEMI. You can have shortness of breath. They talk a lot about some of the more minor symptoms that are seen, like fatigue, malaise, nausea, just feeling poorly. Those are always a little difficult for me because you're sort of straying into the territory of, well, you know, I have those at least, you know, once a month. So am I having a heart attack every month? Maybe not. In addition, the types of heart attacks that we end up having to take to the cath lab rarely present with such subtle symptoms. They'll usually present with some major form of discomfort, some major form of shortness of breath, one or the other, oftentimes both. All right, they're just showing you here that a heart attack can mimic a lot of other common pathologies. You can have gastrointestinal discomfort. You can have shortness of breath that makes you just think you exercise too hard. The key here is that it's got to be compared to a baseline, right? If it's, oh yeah, I was always able to run 3 miles and now I ran 300 feet and I'm completely winded, well, something's not right. I mean, you know, it's not that your body just became incredibly deconditioned that quickly. All right. They're showing you some more of these high-risk groups, the elderly, women, diabetics. Again, we talked about that. Physical exam. All right. So the classic sign of a myocardial infarction is what's called Levine sign. It's a patient who clutches their chest with this exact gesture right here. And it's amazing how typical it is. People really do this. It's kind of involuntary. I don't know why, but there's something about this. Again, the name is Levine sign that usually indicates that it is an anginal type of chest pain. But there are other clues that the patient may have a high risk of myocardial infarction. They went ahead and picked on one particular state there, but yes, there are regions of this country where people are more fit and regions where there are less. Mississippi always leads the country in obesity. Colorado is always the least obese state in the US, at least for the past 20 or 30 years. If the patient has a sternotomy, that's what they're trying to show you over there on that right-hand figure. If the patient has a sternotomy, obviously someone has already been into their chest for something. The number one cardiothoracic surgery performed in the US is bypass surgery. Just be aware, it could be that they have a sternotomy because they had a heart valve or because they had to have a repair as a child, et cetera, et cetera. So not all sternotomies are bypass. And if the patient is eating pork rinds soaked in butter at the bedside, that may be an indication that they are living a high-risk lifestyle. Same thing if you walk in and the room smells overwhelmingly of tobacco and you walk out smelling like the Marlboro Man. That may be the most impressive jugular venous distension I've ever seen. If you see that, the patient is in a whole lot of trouble. They are not moving any blood forward, they're moving all of their blood backward. Now, we talked about shock earlier, okay? The scariest thing you can see in a heart attack is a patient who is awake, talking to you, seems to be feeling reasonably well, but all 4 extremities are cool and clammy and the patient is pale. That's cardiogenic shock all day and twice at night. Okay, these are people that you need to be very scared about. If they have an ischemic EKG and they look like they have cardiogenic shock, they can up and die on you within 5 minutes. So you got to be very aware of that presentation. Generally speaking, when the heart doesn't have enough blood flow, like we talked about, it can't adequately charge up that aorta. It can't get that fluid going forward. You're going to get low blood pressure. Okay, we talked about the signs and symptoms. This is actually from a really cool article series that I did a book review on actually years ago, where they looked at the evidence behind our physical exam maneuvers and said, okay, how much of this is just urban legend and how much of this is real? Well, these are the things on your screen right here that are real. Okay, we talked about how that right arm actually means more than the left arm. Yeah. So the right arm, if they have radiation over there, that makes it 5 times more likely that they're having a heart attack. If you have a patient who says, oh, it hurts when I take a deep breath, very rarely is that going to be a heart attack, okay? Heart attacks are a continuous sort of pain. They don't get better and worse as you take a breath unless they're so overwhelming that they also cause pericarditis along with it. Positional, again, you're usually looking at pleuritis, you're usually looking at pericarditis. Those patients feel worse when they're laying down, better when they're sitting up. Sharp pain, reproducible pain, not usually likely to be a heart attack. If you can point to a patient and go, boop, is that the pain that you were feeling? Oh, yeah, that's it. Okay, that's not a heart attack. 100% of the time. Okay, we'll make it 99 so that we don't get sued, right? 99% of the time, if you can poke a patient and they go, oh yeah, that's it, you're done. Whatever it is, it's musculoskeletal. Now just figure out whether they fractured a rib, sprained a muscle, you know, whatever it is, torn rotator cuff, something. All right, very good. Heart attacks develop because of a complicated process. It's not just that the artery suddenly plugs up with fat. That's a misconception. What happens is you build up fat over time in your arteries, and every single person in this room has at least some fat buildup in their arteries, okay? Even you guys. I know how hard you're working, but everybody's got some. What happens, though, is that in people who are genetically predisposed and who have the appropriate risk factors, those fat buildups increase and they trigger an autoimmune reaction where the body brings in immune cells, starts chewing up fat, and builds it up into a giant inflammatory reaction. That then leads to deposition of calcium in the arteries, and that leads to enlargement of the plaque space and weakening of the wall of the artery on the inside. Eventually, what's going to happen is that inflammation is going to reach such a high level at an unpredictable point in time that that artery is going to rupture from the inside. Okay, the outside of the artery will still be okay. It's not like blood starts squirting out into the middle of the chest. The outside's okay, but the inside is going to rupture catastrophically. Explosion. The body sees that injury and says, oh my God, we have a serious problem here. We got to fix this ASAP. So it recruits all of the clotting signals that it would use for any other injury, right? You know, the body has evolved to survive days and weeks, not years. So it brings in the clotting response, slaps some platelets on the spot where the plaque just ruptured, and then tries to lay down clot on top of it. If the body lays down enough platelets, it'll completely occlude that artery. The patient will have a heart attack that'll show up as a STEMI on EKG. If they only partially occlude the artery, or if they occlude the artery with unstable platelets, you know, they build up in a pyramid and blocks the blood flow, but then the blood flow knocks a bunch of the platelets over and it gets through again, but then it builds up more platelets. That's how you get unstable angina. Okay, that's where you get that waxing, waning chest pain. The artery's trying to occlude, the blood flow breaks free. The artery tries to occlude again, more blood flow breaks free, so on and so forth, until eventually the artery completely occludes. All right? All of the interventions that we make are designed to interrupt this cycle that I just talked to you about. So what are the things that we give? We give aspirin. What does that do? Antiplatelet, right? What do? We give some sort of Plavix or Brilinta or Effient. Those are also powerful antiplatelet agents. We're trying to shut down that first phase reaction. What else do we do? A lot of times we give heparin or low molecular weight heparin. That's designed to keep the body from depositing these reinforcing fibers, from cross-linking factor 13 and from forming organized clot that's even harder to get rid of than the platelets. Okay, so these are sort of the measures that we take. And then the intervention that we make is designed to knock that obstruction out of the way or dissolve that obstruction. So thrombolytics dissolve that obstruction. Cardiac catheterization knocks it out of the way. All right? So what sorts of things do you see when you have infarcted an artery? Well, we've got this sort of picture over here showing the various types of problems that can occur. So at first, with an incomplete occlusion, you're going to have a portion of myocardium not receiving blood flow, and that's going to cause abnormal depolarization to repolarization from the inside to the outside of the heart. That's going to result in T-wave inversion because of the repolarization portion. But as that ischemia continues to progress, you're not just going to have T-wave abnormalities, you're going to start changing that ST segment. Now at this point, the inside of the heart is wholly different than the outside of the heart in how they're activating electrically, because the inside is the spot that loses blood flow first, and the outside of the artery holds on to its blood flow until the very last minute. So that's where that ST elevation comes from. And then as that tissue actually dies off, you develop Q waves in the leads that are affected by this territory. And you know, when we get to cardiology 3, we'll talk about the territories briefly, and that can help you figure out where in the heart this is occurring. Okay, so we've got a couple examples right there. Unstable angina could look like nothing because unstable angina is going between complete occlusion and no occlusion, right? So what they're showing you there for the unstable angina slide is during a phase when the blood flow is intact. End-STEMI is where the thing is mostly closed off and most of the blood flow is occluded, but there's still a little bit. And then STEMI, the whole blood flow is cut off. There's nothing left. The inside and the outside are maximally different from each other, and you get that big giant ST elevation. Okay. We're going to take just a second here. There are 3 arteries that I mentioned earlier that generally supply the heart. That is the LAD, the left circumflex, and the right coronary artery. These arteries generally have a place they like to go, but each person can have individual variations, and there are congenital anomalies that can mean a patient can have as few as 1 coronary artery supplying the entire heart. However, for the sake of diagnosis, we usually simplify this into a few territories. We call V1 and V2 on the EKG the septal leads. That's almost always the LAD. We call V3 and V4 the anterior leads, front wall of the heart. That's also usually the LAD. And then the lateral leads come in 2 flavors. There's what we call the high lateral leads, that's 1 and AVL. And then there's the true lateral leads, which are V5 and V6, which are really looking way over there at the side of the heart. Either the left circumflex or the diagonal branch of the LAD can supply this. And then finally, there's the inferior territory. This is usually the right coronary artery or the left circumflex artery kind of wrapping around to get that inferior portion. So when you see these changes, they tend to be grouped into one of these segments. And so when you look at it, you can kind of take a guess at what's going on. And as you get good at reading EKGs, you'll say, we have an inferior MI or we have an anterior MI, something like that. Okay. Guidelines basically require that you have at least 2 contiguous leads. That means V1 and V2, V2 and V3, V3 and V4, or contiguous within a territory. That could be 2 and 3. They're contiguous in the inferior territory. It could be 3 and AVF. It could be 2 and AVF. You have to have 2 leads essentially either in the same territory or in an adjacent territory to diagnose this. You need 1 millimeter of J-point elevation to call a STEMI. Or out of safety, we say if there's a new left bundle branch block, or we don't know if there's a new left bundle branch block. In other words, your EKG today has left bundle branch block, and either the patient definitely didn't have that before, or we don't know. In a compatible clinical scenario where they're, oh, it hurts so bad, you have to assume that that is a heart attack, okay? Because that is usually an LAD occlusion. The remainder of the criteria are right here for diagnosis, and I'd encourage you to refer back to the video for an individual discussion of each of these territories. All right, now one of the key features of a true STEMI is that there is almost always what we refer to as reciprocal depression. That means there's a territory that's got ST elevation, and there's a territory that has ST depression, and the 2 are usually the opposite. So if you look at the EKG on your screen, you can see that we have an anteroseptal MI. We're using the antero V3, V4, and septal V1, V2 territories to see our ST elevation. But what we also have is reciprocal depression. Look at 2, 3, and AVF. Those ST segments are actually depressed below the baseline. This is one of the key features that separates pericarditis from a myocardial infarction. Okay? Pericarditis almost never has reciprocal ST depression, and MI almost always does. Okay, so if you see ST elevation everywhere and the patient's complaining of sharp positional pain, probably pericarditis. If you see ST elevation in 1 or 2 territories with some reciprocal changes and the patient is complaining of a crushing dull pain, that's probably an MI. All right, and again, just a little highlighting there. Okay, so when we look at this EKG, this is showing global ischemia. This is ST depression everywhere, and most concerningly, there's ST elevation in AVR associated with all of this global depression. This is actually a very concerning EKG. This usually means the patient is knocking off their left main artery, which supplies both the LAD and the left circumflex. So just be aware of this variant right here. Okay, so who needs acute PCI? The answer is, in the modern era, anybody who's having an acute MI needs an acute PCI. The question is, do we have to wake you up in the middle of the night for it? And the answer is, if you have a new left bundle branch block in the setting of obvious troponin elevation and ongoing chest pain, needs to happen. If you knocked out the inferior wall, probably needs to happen. If you knocked out the posterior wall, probably needs to happen. There's a lot of things here that you can look at. The bottom line is, any patient who comes in with obvious myocardial injury, EKG changes compatible with ischemic process, and inability to eliminate their chest pain needs to be in the cath lab as soon as possible. Okay? If a cath lab is not readily available and that's going on, and they meet criteria for STEMI, then you need to look towards your thrombolytics. Okay, there's a flow chart that's probably too small to read on a slide. Again, refer to your ACLS algorithms for a discussion of the ambulance-based triage or ED triage of a suspected acute MI. An aortic aneurysm is probably the thing that we fear the most when we think it's an MI. So patient comes in, they have terrible pain, oh, it hurts so bad. Most of the characteristics are typical. We're getting ready to take them to the cath lab. The thing that we need to make sure we're not getting fooled by is an ascending aortic aneurysm. So if you have a rupture in progress of the aneurysm and you go jamming a bunch of catheters up there, you can get into all sorts of trouble. Okay, this is how John Ritter died. He went to a hospital in California. They said, this is clearly an MI. Let's go. Did no additional testing, took him to the cath lab. Oops, didn't work out. Okay. There are also abdominal aneurysms. These are also very dangerous, but are not necessarily requiring surgical management. Oftentimes medical management can be associated with these. These are very, very frequently the product of smoking, along with risk factors, hypertension, hyperlipidemia, connective tissue disease. All right, very good. And then the worst consequence of an aortic aneurysm is this thing that John Ritter had, the thing that I'm telling you we're all afraid of, which is aortic dissection. So this is where the blood vessel goes from being dilated to being torn. And when this happens, the blood vessel does not usually tear through and through. It doesn't happen that way. It rips the inner layer. Okay, so the inner layer tears. Blood shoots through that rip in the inner layer and starts injecting itself into the middle layers of the aorta. And because that blood is under high pressure, it tends to split that tissue apart, creating even worse process as it goes along, until eventually either the patient dies or the thing clots itself off, and there's no more pressure pushing that dissection forward. That dissection can manifest in a couple of ways, but they all have kind of the same element. Since you're expanding that middle lumen, what you're also doing is knocking off whatever is terminal to that lumen. Okay? So as it goes backwards, you're knocking off the aortic valve, you're knocking off the coronary arteries, and so you can see wide open aortic insufficiency. You can see the patient develop a profound MI. That's the key there. That's how you can diagnose an MI that's really an aortic dissection. Where CT scan becomes your best friend, okay? Or if you go downstream, you can knock off the kidney arteries, you can knock off the leg arteries, the patient can show up with a cold limb, even though what they were originally complaining of was chest pain. Well, how does that happen? They probably have a dissection. Get that scan, okay? They started their dissection up here, they ran the dissection down, and now they've dissected off, the left femoral artery, and they have no more blood flow. All right. Aortic injury, lots of ways to do it. Trauma is the overwhelming majority of it. They've got the grading scheme right there. I got a question at the break about isn't the most common form of obstructive shock attention pneumothorax? And the answer is yes and no. Attention pneumothorax isn't a direct obstruction to the left ventricular outflow tract because the left ventricle can operate under such high pressures that it usually exceeds the pressures of the tension pneumothorax. However, the tension pneumothorax physically smashes the heart up against the side and physically squeezes those vena cava vessels that are coming back. So that decreases the venous return and prevents the right ventricle from adequately expanding to provide useful blood flow to the left ventricle. So it's obstructive in a way and non-obstructive in another way. Pneumothorax can happen to a lot of people. This is primarily something that occurs spontaneously in COPD patients, okay? Their lungs evolve into these sacs that we call blebs, and if they pop one of those because the bleb becomes too big, because the tension on that wall is too high, they're going to rupture a hole out into their thoracic cavity. They're going to start putting air out there. So it shouldn't be super surprising that this is associated with cigarette smoking. Connective tissue disease is also prone to causing this. If you have a problem with your collagen, you're going to have a problem all over with your body in any sort of stress-bearing vessel. How does this show up? These people have pleuritic chest pain. They have decreased breath sounds because that lung is collapsed. They're no longer filling that space, so there's not going to be breath sounds right up against the wall for you to hear. They're going to feel short of breath. Their heart rate is going to go up because the blood is now going through less lung tissue. Have to make up for in heart rate what you're lacking in easy blood flow. Great question. Stent is preferable to TPA if at all possible. Just to answer one of the audience questions there. Okay, very good. Let's move on from there. Pulmonary embolism, I think we've talked about adequately in the previous section. Esophageal rupture, this is a real problem. Boerhaave syndrome is the most common spontaneous cause of esophageal rupture. That is where you vomit so much that you physically tear your own esophagus from the force of repeated vomiting. Okay, so that's Boerhaave syndrome, and again, the history will be the patient has been having tremendous vomiting, suddenly followed by throwing up a bunch of blood, severe chest pain that isn't relieved by anything. However, the #1 cause of esophageal rupture outside of that is going to be botched intubation. Okay? So when you guys are out in the field, remember, it doesn't make a difference whether the tube goes in 5 seconds or 25 seconds. Okay? Take that extra time to make sure that you don't have your stylet jammed out to some weird angle. Take that extra time to make sure that you're going to have a smooth passage. Okay? I do a lot of medical legal casework for various lawyers around the U.S. One of the cases we're litigating right now actually is someone who was in a hurry, wanted to go back to his own department, did an intubation in what is reported to be less than 30 seconds from start to finish, didn't intubate anything. He just perforated right through the esophagus and, obviously badness ensued. All right, tamponade, we talked about this again in the last segment. What they're showing you here, though, is kind of how tamponade occurs. So if you look at your slide over there, there's a couple of things. And is there any way for you to use a cursor on the slide there? No, not really. Okay. Well, if you look, oh yeah, there you go. You got it. Let me have that. Perfect. Thank you. I'm going to step off camera here for a second. Let's see if I can get this to work. Yeah, so if you look right here where I have this finger, this is the pleural, or the pericardial space rather. This should be empty or an extremely fine black line, okay? But instead there's this very large area right here that looks to be about 2 centimeters wide. This then is the right ventricle right here. This is a subcostal view of the heart. And what's happening is this fluid is pushing up against this right ventricle. It can no longer expand to its fullest extent. The other thing that is just starting to become apparent is that the right atrium over here can't quite fully expand as well yet either. Not the best example of that ever, but certainly an example. Okay. Wow, that guy with the knife in his chest is probably at pretty high risk of tamponade as well. We talked about Beck's triad. We talked about the pulsus paradoxus. That's where the blood pressure rises and falls significantly as the patient breathes in and out. And then on an EKG, you can see that the voltage gets bigger, smaller, you know, as the heart sort of flips around in this bag of fluid that's surrounding it. We've got a little differential for you there. We talked about that as well. And on we go. All right, pericarditis. I mentioned this briefly earlier. Pericarditis is a usually virally mediated or autoimmune mediated inflammation of the heart lining. Okay, doesn't have to be just the heart, can also be the lung lining. Causes ST elevation all over the place, but, and I'm going to point this out for you right here, the subtle finding, the pro-finding of pericarditis is PR depression. So from the end of the P wave to the start of the R wave is actually a little bit below the baseline, particularly in the inferior leads. And then when you go over here, it's slightly elevated in AVR. The key here, no reciprocal depression. Lots of ST elevation, absolutely no reciprocal depression. When you have the appropriate clinical setting, when you have this EKG finding, when you have that supportive PR depression, you're getting pretty close to making a diagnosis. All right, endocarditis, this is very simple. This is a bacterial infection of the heart or its valves. It manifests by throwing off little flecks of bacteria all over the body. So you can see little collections of bacteria in the eyes, the skin, the hands. GERD, the final cause of chest pain, that should be your diagnosis of exclusion, okay, not your first thought. You want to make sure you're looking for all these other things, then turn to the GI tract if all of that fails. All right, we're going to take another break. All right, here we go. I got a couple questions from the audience over here. Question number 1, is it CoxHealth policy, SOP, or best practice for all field STEMI patients to go straight to the cath lab for PCI? That is the ACC AHA guideline and has now been incorporated into ACLS trainings that cardiac catheterization is the preferred modality of treatment for STEMI. All around the country, programs are always all about how fast can you get them to the cath lab, how fast can you get that intervention done. But for places where that's not always technically feasible, thrombolytics are still an option that is used and used successfully. Second question, in the presence of a STEMI, is nitroglycerin better used in pill spray form or an actual drip titrated to effect in BP? Well, this is sort of a misnomer. In a STEMI, nitro won't be effective. Period. The artery is closed off like we talked about. This is a complete occlusion of the artery. You can dilate it as much as you want. It is still clotted off. So the patient is not going to get relief from nitroglycerin. However, in the lesser forms of acute coronary syndrome that we talked about, the sort of stuttering unstable angina or chronic stable angina, something like that, that's going to respond better to a nitro drip on the whole, but you'll get a more immediate response off of a sublingual nitro. You're basically giving a controlled oral overdose of nitroglycerin with those tablets. That's what that's all about. So yeah, over time though, you're going to want to have that drip if you need long ongoing control. Okay, that being said, let's start with cardiology 3, please. Okay, dysrhythmias, and let's go ahead and get going. Actually, where's the, there we go. All right, perfect. Okay, and can you throw up the preview window for me on the side as well? The cardiac action potential and cardiac vectors, I'm not going to spend very much time with you on today because the most important thing for our audience, which is the Special Forces members and our EMT audience, is to understand how to correctly read and interpret EKGs and rhythm strips, okay? So that means we need to be able to correctly look for ischemic changes. That means we need to recognize abnormal heart rhythms and we need to integrate those accurately into our ACLS. Nonetheless, it's important to know that cells start out at a very low voltage. It's actually a negative voltage relative to the surrounding tissues. They then go to a very high voltage, stay at a high voltage for a period of time, and then come back down to that negative voltage. Now, on a cellular level, it looks like the figure you've got there in the blue. It looks like exactly what I just described, but when you add up the billions of cells in the heart all at once, it creates an EKG in the shape that we all know, which is above the blue, with the P, Q.R.S., ST, and T segments. So the electrical conduction system begins with the sinoatrial node way up here where the superior vena cava meets the right atrium. This is an automatic structure. That means it requires no impetus to fire on its own, okay? It will do so if left to its own devices. It fires off an electrical impulse that travels through the atrium and travels over specialized wiring to the left atrium as well. That signal is then picked up by the AV node, and that signal is carried to the lower chambers of the heart by the His-Purkinje system. So it starts out as the common bundle of His, then it splits off into the common left bundle and the right bundle, and then the left bundle splits into two more bundles called the left anterior fascicle and the left posterior fascicle. This then makes up the entirety of the cardiac conduction system. So think of it like this. We've got 3 electrical branches and we have 3 arteries like we talked about earlier, right? Okay. So these are responsible for creating a unified contraction. The most important thing for the heart is to squeeze together explosively. And that's why we have these superhighways with these big distribution networks to get that heart to contract explosively in one big movement. Now, all of this electrical activity that I've just described manifests on the Q.R.S. So the P wave is the depolarization of the atrium. Then there's a silent period while the AV node slowly conducts that electricity through. Now, what is that? That's a time delay fuse that gives the atrium time to finish its squeeze and get that blood into the lower chamber before we fire off the lower chamber, okay? That AV node is also very important because the top chamber is prone to abnormal fast rhythms, things with names like atrial fibrillation, okay? And if we conducted every single upper chamber impulse to the lower chamber, we would turn atrial fibrillation into ventricular fibrillation. That would be bad. So, again, it's a safety mechanism and it's a time delay mechanism to let the atrium coordinate with the ventricle, all right? Now, when the ventricle starts firing, that creates the Q.R.S. complex, okay? That's the squeeze of the lower chamber. And buried in there, so small that you really can't see it, is the repolarization of the atrium. Then there's a silent period while the ventricle sort of finishes its contraction, and then there's that T wave as all of that tissue from the ventricle relaxes and everything goes back and resets for the next beat. Sometimes there is a congenital abnormality in the patient, something they were born with, where some cells kind of got lost in between the top chamber and the bottom chamber. They're little and when the message came and everybody said Red Rover, split up, these cells just said and missed the bus, right? So they form a bridge between the top and the bottom chamber that should not be there. And most importantly, that bridge is usually a very high quality electrical connection. You say, well, isn't high quality good? No. Remember, we have that special safety thing in there with the AV node. We want to prevent too many signals from getting to the lower chamber. Otherwise, the lower chamber gets scrambled and you end up with VT or VF. So these accessory pathways pose a significant risk of sudden cardiac death if they're good enough. And that's where you need someone like me, an electrophysiologist, to go in there, figure out whether the accessory pathway is safe or dangerous. And in the vast majority of cases these days, we just delete these things and then we don't have to worry about them anymore. All right. The autonomic nervous system in the heart, we talked about a little bit. The heart reacts via chemicals to parasympathetic stimulation, reacts to acetylcholine, right? And reacts to direct nervous stimulation for sympathetic activity. However, circulating epinephrine levels can also increase the cardiac activity, okay? So circulating dobutamine, circulating epinephrine, norepinephrine, isoproterenol, some of these chemicals that you have available to you. All right? We talked about these sensors. There are not very many sensors. There's 4 in total, 3 of which are used under normal circumstances. We got the neck sensors, the aortic arch sensors, and the kidney sensors that tell our body whether the autonomic system is running too hot or too cold. And then as a last resort, and they actually did a nice job drawing it on there, there's some little fibers that are on the side of the ventricle, and those, when they slap into each other, say, whoa, 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 I don't know what's happening, but that heart is working way too hard. Let's just take it down a notch. You don't ever want to see that reflex. That causes big collapse, and it usually is the result of hypovolemic shock. It's usually, you know, the patient's bleeding out or someone ruptured a ventricle. All right. Causes of cardiac dysrhythmia could be anything. People always say, well, what did I do to cause this? I don't know. Got unlucky that day. But there are things that can make it much more likely, okay? So if you make the heart more irritable, more ramped up, it's more likely to misbehave. And that's true for us too, right? I don't let you sleep. I feed you, you know, too much caffeine and pre-workout, and, you know, get you all ramped up by saying nasty remarks about your mom or something. You're more likely to start a fight you wouldn't normally fight, right? Same idea is true with the heart. We can provoke this with excesses of amphetamines, caffeine, cocaine, you know, any of these sorts of things tend to get the heart really excited. If the patient's in an adrenaline overload state, that can tend to happen. So emotional distress, not uncommonly associated with cardiac dysrhythmias. Now, all these arrhythmias that I'm talking about when I talk about these things are fast rhythms. It's also a cardiac dysrhythmia to go too slow. It's very rare that anything other than medications and aging cause a real slow heart rhythm. Okay, it's kind of medications, aging, and heart attacks are the three things that cause slow heart rhythms for the vast majority. Okay. We put electrodes on the right arm, and left leg. I'm going to skip through the next several slides because this is very low yield material for the vast majority of you guys learning how to calculate electrical vectors of the EKG. If that's of interest to you, please go back and review that material. I cruised through the slides there slowly enough that you should be able to pause. Okay, what is important is to be able to describe your EKG on paper. All EKGs are taken at a standard in which each vertical small box is 0.1 millivolts and every horizontal box is 0.04 seconds or 40 milliseconds. Each big box is 200 milliseconds wide or 0.2 seconds, okay? And there are normal intervals, okay? So the normal time from the start of the P wave to the start of the QRS is less than 1 big box or 5 small boxes, okay? It's less than 200 milliseconds in the overwhelming majority of cases. The QRS duration should be smaller than 3 small boxes. It should be less than 120 milliseconds, okay? The J point and the PQ interval, the time where the atrium is done but the ventricle hasn't started yet, should generally be on level. There are a few exceptions to that that are beyond the scope of this lecture today, but generally speaking, you should have a nice steady baseline with these deflections above and below that baseline. Okay, when you learn to read EKGs, it is possibly the most frustrating thing ever. I just want to talk to you guys for 1 second. I train nurse practitioners in the electrical service to read EKGs, and it universally takes 3 months to teach them how to do it properly. And it is exceptionally frustrating for even the brightest nurse practitioners we've had, okay? It's frustrating because you don't get it, you don't get it, you don't get it, you don't get it, and you wake up on a Tuesday and you get it all. Every EKG is right. And the reason for this is because EKGs are a cognitive process initially, but they are a visuospatial process once you have it down, okay? So I can teach you the rules, and I will today, but the real trick is you have to do a lot of them. You have to do as many as you possibly can, okay? I calculated the other day that I'm somewhere north of 500,000 EKGs in my life that I've looked at, okay? In terms of rhythm strips, you need to see as many as you can until someone shows you something, they go, well, those are P waves. And you say, well, why are they P waves? Because they look like P waves. That's the real answer. You have to see enough that the pattern recognition sets in, and you go, well, because it just looks like it. That's what it's supposed to look like. Okay? This happens whether you're an EMT, this happens whether you're an electrophysiologist. This happens to everybody who needs to read EKGs reliably, but I am going to walk you through the process of how to train yourself to do this. There is a book by a man named O'Keefe called The Complete Guide to ECGs, I believe. Don't quote me on that big yellow cover. If I were to recommend only one book to learn how to read EKGs by pattern, it would be that book. It has a great introductory section and has an enormous number of EKGs with comprehensive explanations for why each one is what it is. The only caveat I'll give you, there are a few spots in that book where he's not entirely right about his reads on the EKGs, but that's pretty rare. So overall, still the best book I know of. I still use it to train all our staff. All right, let's get on with it. You need a system to read an EKG. Okay, you have to have an organizational pattern or you will miss things when you first start. So let's start with the rate. Okay, is this thing going too fast? Is this thing going too slow? If it's going too fast, it's a tachycardia. If it's going too slow, it is a bradycardia, right? It's just nomenclature. These are just a lot of fancy terms. There's no reason we need fancy terms, but we invented them, you know, a really long time ago, and it makes us feel special to keep using them, so we're going to keep doing it. Once you know whether it's too fast or too slow, you need to ask two independent questions. What's the rhythm in the top chamber, and what's the rhythm in the bottom chamber? Because they're not always the same thing. You can have the top chamber going along and only some of those beats are getting to the bottom chamber. You can have the top chamber completely quiet and the bottom chamber is going along without it. You can have the bottom chamber running away for dear life and the top chamber is beating like normal. Okay, all of these are possible. Axis. Axis is the lowest yield item for you guys to discuss when you're first starting on EKGs. Again, if you want to know about axis interpretation, I would encourage you to refer to some of these materials that I've referenced to you. Intervals. You need to look for abnormal intervals. Is the PR too long? Is the PR too short? Is it less than 3 boxes, more than 5 boxes? Both of those are abnormal. The QT interval, very important. That QT interval determines the likelihood that you're going to develop polymorphic ventricular tachycardia, also known as torsade de Pointes, right? So torsade is just polymorphic VT in the setting of long QT. That's all it is. The RR interval is not important. You already answered that back when you said, is it too fast or too slow? Okay. And then finally, you need to analyze the segments themselves. Is the PR segment on level? Is it elevated? Is it depressed? What about the ST segment? That one's even more important. That's where you determine whether you've got a STEMI. Is the ST segment way too high? Or are there a bunch of ST segments that are too low? So use this system as you're going through your initial EKGs to try and minimize the amount that you're missing. All right. So, bad joke there. Now, we're going to get into very specific terminology. Okay? This is extremely important that you recognize a lot of this stuff is simpler than it looks. It's just that we put different names on things depending on how fast they're going or how many times it does it. Okay? If you can follow along with me on that, you're going to do a lot better. Remember, sometimes it's the same thing, it just has a different name if it's fast than if it's slow, and sometimes it has a different name if it repeats over and over again. So, the first rhythm up in your top left there is normal sinus rhythm. That means a heart rate between 60 and 100 beats per minute. Some people modify the definition slightly to say 50 to 100 beats per minute. That is not technically appropriate. Bradycardia begins at 60 beats a minute and below. But what they're trying to do is keep you from calling something abnormal just because, you know, a well-conditioned person has a heart rate of 52, right? Now, if sinus rhythm, the normal rhythm originating from that high lateral right atrium, starts going faster than 100 beats a minute, then we change the name. Now we call it sinus tachycardia, right? And if the sinus node slows down below 60 beats a minute, then we call it sinus bradycardia. So how can you quickly figure out what the rate is on an EKG? Well, the very fastest way is to just count how many big boxes it is between each of the QRS complexes. If it's less than 3 big boxes, it's tachycardia. If it's more than 5 big boxes, it's bradycardia. The more advanced version of that is to be able to count the big boxes as you go across. So it goes in sequence. It's 300, 150, 100, 75, 60, 50. The way you figure that out is it's 300 divided by the number of big boxes is equal to the heart rate. Okay, so if you read EKGs professionally, almost everybody who does has that 300, 150, 100, 75, 60, 50 sequence memorized, and they can just go through it. But if you're trying to get it as quick as you can, count the big boxes. Less than 3, tachycardia. More than 5, bradycardia. Okay? Now, the sinus node is creating a regular sequence of beats, but the heart is just a muscle. If you don't get enough sleep and you drink too much caffeine, you're going to get a little eyelid twitch, right? Well, same thing's true with the heart. If the heart gets irritable, if you feed it too many stimulants, you get too dehydrated, it's going to start twitching as well. Okay? Those twitches can occur in the upper chamber or the lower chamber. If those twitches occur in the upper chamber, they are called premature atrial contractions, PACs. And the way that you identify them is that you have a P wave that's way earlier than it should have been. So if you sit there and you march out with either a pair of calipers or a piece of paper that you've made a mark on, where all the other P waves are, you can keep moving that across the page, and all of a sudden you'll see a P wave that's way in front of all the other P waves. And there's usually a pause afterward. Okay, that's sort of the number one thing that trips you off. They've got a good example of that right there. So you've got a sinus rhythm going along, and then on the 4th beat, there's a P wave that came in way earlier than it should have. And then there's a big long interval between that QRS and the next QRS, because this thing came in early and interrupted the timing that would otherwise have been there. It's like when someone cuts you off when you're talking, right? You're in the middle of a sentence and someone goes, but, and you're like, wait a minute. And it takes you a second to get back to the rhythm of what you were talking about. Okay. Now, the sinus node is not a 100% reliable structure. As you get older, as you have more atrial fibrillation, as you're placed on more drugs, that sinus node becomes less and less reliable. When the sinus node becomes unreliable, you can have things called sinus pauses, or the worst form of sinus pause, sinus arrest. And what that is that the sinus node is either no longer generating its heartbeats, or it can no longer get those heartbeats out to the rest of the atrium. Either one can happen. So what that results in is a sinus rhythm that's just going along, minding its own business, and then boop, nothing. There's no P waves anywhere along the strip. It's just flat baseline, and then you get your P waves back. Okay, so they've got a reasonable example of a sinus pause on the screen for you right there. Finally, there is something that is not a bad rhythm at all. You just need to know the name of it so that when you see it, you can describe it to somebody. This is called sinus dysrhythmia. Okay, sinus dysrhythmia is particularly prevalent among people who are well conditioned. So the younger they are, the fitter they are, and the slower they are, the more likely you are to see this sinus dysrhythmia. What this is the heart rate speeding up and slowing down as you take breaths in and out. Because if you're well conditioned and you're relaxed, as you breathe in and out, your autonomic nervous system comes up a little bit and down a little bit. Okay? And it alters your heart rate. So you can see the P waves are a little closer together over there on the left of the strip. Then it starts getting a little further apart as the strip goes to the right. Okay? So that's sort of sinus dysrhythmia. The key there is that the waves look like sinus. They're just not perfectly evenly spaced. All right? Now, the top chamber can develop a number of abnormal rhythms, and those rhythms can be a point rhythm, a loop rhythm, or a chaos rhythm. Okay? Chaos is like static, static on a TV screen. There is no discernible electrical pattern at that point in time. We call that atrial fibrillation when it occurs in the top chamber. Okay? My job is to put wires up into people's hearts and measure the electrical flows that are going around up there. And even when I use my very best wires with my very best equipment, there is no pattern to that electrical flow that we've yet learned to figure out. Okay? It's just pure chaos. Electrical signals everywhere, never repeating, no sequence, no pattern. And so because of that, the baseline, and again, I'm going to step away and use this mouse here, This baseline looks just as chaotic as the atrium is. There is no discernible P wave. There is no reliable isoelectric baseline. It just looks like a noisy tracing on that baseline because the atrium is just sitting there quivering. Now, that rhythm can come from and go to a more organized rhythm called an atrial flutter. Now, an atrial flutter is a loop rhythm. Electricity is going round and round in a perfectly controlled loop over and over and over again. And one of the most common things I do for people is I go into their heart, I figure out where that loop is, and I break the loop so that they can't have that anymore. The most common version of atrial flutter is what's called typical atrial flutter, and they have a reasonable example of atrial flutter here on your screen. It's not ideal because the ST segments there don't look like they usually look, but this is sort of that characteristic down slow, up fast morphology in the inferior leads. So on leads 2, 3, and AVF, you want to see that down slow, up fast pattern. And in V1, if you have it available to you, it creates narrow, pointy P waves, okay? So when you see that pattern, it's perfectly regular. You can take a caliper or a piece of paper and every single one of those little peaks is just gonna march out right across the strip. You could run that strip for 1,000 feet a strip and it'll just keep marching all the way along. It is mechanically regular, okay? It's going to go at the exact same tempo all the way through. Now, wandering atrial pacemaker means that the sinus node is not completely dominant in the top chamber. It means that there are some other places that sometimes want to lead. And so you'll get different shapes of P wave as the strip goes on. So if you look at this example here, you have one narrow, really pointy P wave. Then you have one really broad, lower amplitude P wave. When you get to the second to the last beat, it's kind of goes up, makes a little M-shaped hump there, and then comes back down. So that's 3 different shapes of P waves. And when you see a bunch of different shapes of P waves, that's a wandering atrial pacemaker. Okay? If you have wandering atrial pacemaker, but it's really, really fast, we change the name, and we call it multifocal atrial tachycardia. This is commonly seen in 2 patient populations. We see this in people with lung disease, especially COPD, okay? And we see this in people on diltiazem. For whatever reason, diltiazem often can promote this in people who are vulnerable to having it in the first place, okay? So multifocal atrial tachycardia, think lung disease. Think what's wrong with this patient's lungs. Don't cardiovert that rhythm, okay? If you see a P wave in front of every QRS, then that is probably not going to be a rhythm you're going to want to cardiovert. It's probably not going to work. They're just going to go right back into it. Both wandering atrial pacemaker and multifocal atrial tachycardia are issues in which the heart is too twitchy from spots that really shouldn't be firing at all. Okay? Now, in between the atrium and the ventricle exists that time delay fuse that we talked about earlier, that AV node. Okay? That AV node can actually fire off on its own. And if you lose the signal in the top chamber of your heart, your body is going to try and protect you from dying by developing a series of what we call escape rhythms. Okay? The most reliable source of an escape rhythm for a human being comes from that AV node in what we call a junctional escape rhythm. And the key to a junctional escape rhythm is that there are no P waves in front of it. So you have narrow QRSs going all the way across your strip with no P waves in front of them, okay? So you can kind of see that here. Where are the P waves? Well, the P waves are buried in the QRS. Because when you're firing the junction, you're firing from the middle, right? So you get the atrium and the ventricle to fire at the exact same time, which means that their electrical signals occur at the exact same time. But the left ventricle has so much voltage, so much mass, that it completely overwhelms the electrical signal of the atrium, and you often can't see it at all. All right? Now, this is another situation where we change the name depending on the rate. If it's a rate between 40 and 60 beats a minute, we call it a junctional escape rhythm. That means the heart doesn't have anything better to do, so the body's throwing that safety rhythm just to make sure you're okay. This is the normal state for healthy people, that they will develop a junctional escape rhythm if their top chamber goes completely silent. If it speeds up over 60 beats a minute, that's faster than we expect. Okay, that usually means something's going on. The patient's got a medical illness going on, or they've got some sort of stimulant on board, and that results in an accelerated junctional rhythm. That's any junctional rhythm that's between 60 and 100 beats a minute. And then, once again, if it goes over 100 beats a minute, we got to change the name again because I don't know why. And now we call it junctional tachycardia. Okay, so 40 to 60, junctional escape. 60 to 100, accelerated junctional. Greater than 100, junctional tachycardia. And then, if you're going along in sinus, and then all of a sudden you see a QRS complex with absolutely no P wave in front of it, that is a junctional premature beat or premature junctional beat, either one. Okay. Now, we've talked about abnormal rhythms from the top. We've talked about abnormal rhythms from the middle. So, of course, we have to talk about abnormal rhythms from the bottom. We talked about twitchy beats in the top. We told you they're called PACs, premature atrial contractions. They create a P wave followed by a narrow QRS. Okay? This is a PVC. There is no P wave that causes it. It's premature, and it creates a wide complex beat that looks nothing like the regular beats. Okay? If you have a bunch of PVCs, then we start changing the name depending on how many of them you have. So if you have 2, we call it a couplet. If you have a PVC for every other normal beat, then we call it bigeminy. Normal beat, PVC. Normal beat, PVC. We call that ventricular bigeminy or PVC bigeminy. If you have a whole bunch of different shapes of PVCs, we call it multifocal PVC because the shape tells us where it comes from in the heart. If you do this for a living, you can actually look at the shape of a PVC on a 12-lead EKG and say it's coming from there. And you'll be right to within a centimeter or two within the heart. Now, we talked about escape rhythms a second ago, and we said that if your top chamber rhythm fails, your junctional rhythm is almost always what the heart's going to go to. But what if the junctional rhythm fails? Well, it turns out nature has one more trick left over for us, and that is a ventricular escape rhythm. But the problem with this is we don't want the ventricle firing off on its own under any circumstances normally. We want that ventricle to just follow orders from above, okay? It is not to question why. So, the ventricle produces an unreliable escape rhythm. This is why we don't like seeing ventricular escape rhythms, because they are generally unreliable for saving people's lives, okay? It may be okay 1 minute, and then 1 minute later, it's completely gone. Patient's completely asystole, all right? This is another situation where the name changes as the rate changes. So, if it's very slow, 20 to 40 beats per minute, then we call it an idioventricular rhythm. If it goes faster than that, but less than 100 beats per minute, we call it an accelerated idioventricular rhythm. If it goes over 100 beats a minute, we call it ventricular tachycardia. Okay, so 3 different names for what is essentially the same process. That's the ventricle firing off its escape rhythm. Now, once you get into ventricular tachycardia, it's usually not because it's an escape rhythm anymore. Now the ventricle is usually stuck in a loop. Just like that atrial flutter for the top chamber, this is the ventricle stuck in a loop. And again, this is one of the things that you need an electrophysiologist for, is to go into the ventricle, figure out where the loop is, and try to break it so that this doesn't keep happening. How do you fix this in the field? Amiodarone, direct current cardioversion, right? Amio isn't working, DC cardioversion isn't working, lidocaine you can add on to it, and in the old days, procainamide, also ibutylide. You're probably not going to be using those out in the field. Now, there are a couple of special types of ventricular tachycardia. If the ventricular tachycardia is wide, complex, and just ugly as heck, but it doesn't have a single specific shape to it, we call that polymorphic ventricular tachycardia. And this thing that they've labeled torsades here is a very good example of polymorphic ventricular tachycardia. None of that's normal, none of that looks good, and none of it has the same shape. Torsades is polymorphic ventricular tachycardia in the setting of a patient who has long QT. Okay, so once you get them back into sinus, their QT is long, it looks like that. Okay, the number one cause of polymorphic VT is not torsades. The number one cause of polymorphic VT is myocardial ischemia. It's a manifestation of heart attack. It's the reason that we never see half of all the heart attack victims in the US, because they just drop dead of polymorphic VT and that's the end of them, okay? However, in patients who are taking appropriate drugs, and this is things like antipsychotic medications, things like quinolone antibiotics, these patients develop this very long QT, and then it only takes one bad PVC to completely scramble the lower chamber of the heart, and they end up with a rhythm that looks like this. The reason they call out torsades specifically here is because it has a recognizable shape that gets bigger, smaller, bigger, smaller, bigger, smaller, and because its treatment is sometimes magnesium. Okay? If you give a bunch of magnesium, sometimes you can stop torsades. But in the meantime, don't sit around spending too much time worrying about the magnesium. Worry about the 360 joules to the chest. Okay? Ventricular fibrillation comes in three flavors: coarse VFib, fine VFib, and very fine VFib. Okay? I'm going to talk to you about that third one in a second. Coarse VFib looks like polymorphic VT. The two are essentially indistinguishable. One's just bigger than the other. But on a life pack, I mean, that's just a matter of how much gain you have, right? I mean, if you dial the gain of polymorphic VT down to 0.5, you're going to get something that looks like coarse VFib. The treatment for the two is the same. Shock it, okay? Fine VFib looks like AFib, except there's no QRSs anywhere. It's just a squiggly baseline with no P waves, no QRS waves, just a fine squiggly baseline, okay? Again, treatment, shock it. Okay, there's no fix for VFib except a cardioversion, okay? And then there's asystole, complete electrical silence of the heart. In your ACS algorithm, they're going to tell you do not shock asystole, and I'm going to tell you I am 100% opposed to that. We have, within the past 3 years, 2 or 3 people whose lives were outright saved, and we sent them home because they had asystole, but it was really fine VFib with not enough gain on their EKGs to see the fine VFib. So if you have asystole and you've tried everything to get the patient back and you're in the middle of your ACLS, after you've done a couple rounds and you're not getting anywhere, shock them. You've got nothing to lose. They're already dead. And if it's fine VFib, you're going to see those QRSs come right back. I think it was 4 classes of SOCM students ago. We had a whole mess of you guys up in the cath lab, and we shocked asystole, and sure enough, boop, boop, because it wasn't asystole, okay? Asystole is a diagnosis of exclusion, not a diagnosis of inclusion. Please don't let someone die because you wouldn't give them 360 joules somewhere along the way, okay? Again, off ACLS indication, this is advice from an electrophysiologist who's been in, if it's not thousands, certainly hundreds and hundreds and hundreds of codes. Okay, the top chamber and the bottom chamber are not always related to each other, okay? When they are 100% associated with each other, but they take too long to get from the top to the bottom, that's more than 5 small boxes, we call that a first-degree AV block. Electrophysiologists hate this term because there is no block. Nothing blocks. It all gets through, okay? It just takes longer than you expect it to, all right? So first-degree block isn't even a block. It just takes longer, okay? More than 5 small boxes, more than 200 milliseconds. Then comes the hardest thing for all people learning to read EKGs. You have to separate so-called Wenckebach, which is second-degree block Mobitz 1, from that second-degree block Mobitz 2. So depending on where you train in the country, there's a couple of phrases that people use for this. In the military, they like to say type 1 likes to run, type 2 sticks like glue. What they mean by that is that in type 1, the P wave keeps running away from the QRS until eventually there is no QRS that follows it. And then it repeats that pattern over and over again. Whereas with second degree type 2, anytime there's a QRS, the P wave is the exact same distance in front of it. Okay? Does this make sense? The key is what happens when there's a QRS. If the PR interval keeps getting longer and longer in front of those QRSs before you drop the beat, then that is the type 1 second degree AV block, the Wenckebach. Okay? If that P wave is always the exact same place in front of the QRS whenever you have a QRS, then that is your second degree type 2. Okay? Now, if you can take a caliper or a piece of paper and you can march out all the P waves and you can march out all the QRSs, okay, and the P waves are all regular and the QRSs are all regular, but there is no consistent PR interval, that's third degree AV block. That means the top chamber is doing whatever it wants to do, the bottom chamber is doing whatever it wants to do, and the two are not talking. Okay? The big key here is to see a regular heart rhythm where there is no defined PR relationship. So how do you separate that from Wenckebach? Third degree block never drops a beat. Third degree block is just going along. It's steady, baby. But that P wave has nothing to do with that QRS. You'll see some that are close, you'll see some that are far, you'll see some where you don't even see a P wave in front of the QRS. Okay? In Wenckebach, you're going to see drops. You're going to see some beats, some beats, some beats, and then there's going to be a little pause. Some beats, some pause, some beats, some pause. Does that make sense? Yeah? Okay. All right. Go back, study this. This is without question the #1 thing people miss on their examinations is their various forms of AV block. Go back, play the lecture again. I have no idea why these animations are here, so we're going to blow right through all that. Defibrillation resets the heart. Okay, what defibrillation does is it forces depolarization of all of the cells in the heart, thereby giving them all a chance to reset. All right? In ACLS, they tell you that 200 joules is the amount of energy to be used. Okay? The reason is because 200 joules used to be the maximum amount of energy that defibrillators had. Okay? There have been numerous studies in the electrophysiology literature that now indicate that if you're going to shock the patient, shock them with all the joules. It hurts just as much, is far more likely to be a successful cardioversion, either of AFib or of ventricular arrhythmia. It doesn't really matter. And you are likely to result in overall higher patient satisfaction. The only downside to more energy is a higher risk of thermal burns. That risk, for the most part, exists only if your patches have poor adhesion. Okay? So when you put those patches down, roll the patch onto your patient. Don't slap it on the patient, because if you get an air pocket in there, they're gonna get a burn where that air pocket is. Okay? You got to roll that patch on so that you have complete smooth contact of the patch onto the chest wall. Okay? In female patients where you have breast tissue in the way, go above the décolletage, shall we call it, or carefully spread the patch out so that you maintain even contact and move the breast tissue to the side. But do not allow those pads to fold up and create areas where electricity is going to arc. Defibrillation versus cardioversion is no different than talking about an accelerated junctional versus junctional tachycardia. It's a silly change of name that doesn't serve any meaningful purpose. Defibrillation is when you take a rhythm that has no organization and convert it back to normal, and cardioversion is where you take an organized rhythm and convert it back to normal. Who cares? Well, there's only one reason that they point this out on this slide, and that's because if the rhythm appears to be organized, then you're going to want to use that sync button on your defibrillator. You're going to want to make sure you deliver that shock on the QRS. But if the rhythm is chaotic, right, then you don't care whether you deliver it on the QRS because there is no QRS predictable to deliver it on, right? So Interestingly, they separate these incorrectly on this slide. You can see they've got some polymorphic VT over there on the right, and they have a very regular rhythm over on the left. So if we were to correct this slide, we would take the polymorphic VT, move it over to the left. We would take that organized ventricular tachycardia on the bottom of the left and move it over to the right. Anytime you are cardioverting SVT, atrial fibrillation, or atrial flutter, you should be using that sync button, okay? All right, more jokes, haha. All right, stable versus unstable patients. If the patient is stable, you do not need to cardiovert them, okay? You do not need to shock an awake patient who is stable no matter what the rhythm is, okay? That means they don't have an altered mental status, they don't have hypotension, they're not complaining of severe shortness of breath or chest pain, right? These are the signs that your patient is stable. Let that thing ride. You're probably doing me a favor. The number one limitation in my job is patient had rhythm X out in the field, it was fixed in the field, they brought him into the ER and no strips available. Great, how am I gonna fix that? I have to guess at what the problem was, right? However, any unstable rhythm, whether it's supraventricular, whether it's atrial fibrillation, whether it's ventricular tachycardia, any unstable rhythm is a candidate for cardioversion, okay? The only question is, do you have a better treatment in the bag that you can get done faster? If your patient's complaining of crushing chest pain, they have AFib and a heart rate of 190, you have my permanent permission to go ahead and shock that with or without sedation, whatever the clinical situation requires, okay? All right. Bradyarrhythmias are very slow rhythms. They come in a lot of flavors. Sometimes they're due to heart block. We talked about the heart blocks. Sometimes they are due to sinus node dysfunction. The heart's just not beating fast enough. How do you deal with these? Well, first, you secure the patient, you get your airway, your breathing, you start working on the circulation. How do you fix that? Well, atropine is the ACLS drug of choice, okay? You use a little bit of atropine if they're hemodynamically stable. You use a lot of atropine if they are not hemodynamically stable. If the atropine doesn't fix your problem, after you give it, you transcutaneous pace them to get that heart rate higher. Be careful of transcutaneous pacing, okay? If you look at the literature, it's not nearly as effective as they promise you in EMT training. Okay, only about a quarter of patients will develop meaningful cardiac contraction, and because every time you get that contraction, you're also contracting all the skeletal muscles in the chest, you're working against your heart. And so of that quarter, only a quarter of them will end up having an effective perfusive pressure. So the overall rate of field efficacy of transcutaneous pacing for asystolic arrest is only 10% in the literature series. It's a little higher if the patient just has sinus brady, but that has as much to do with the fact that the pain that you're causing them from the transcutaneous pacing creates an epinephrine response, okay? So again, don't ever say that transcutaneous pacing is the only way you're going to save a life. In the hospital, if we think the rhythm is unstable, we do not rely on transcutaneous pacing. We put a temporary pacing wire in because we know that transcutaneous pacing can be unreliable. Things that make transcutaneous pacing much less likely to work: severe hyperinflated lung disease, especially COPD, very obese patient, and most importantly, and this one is 100% in your control, poor pad placement. Okay, first pad goes right here, second pad goes way over there to the point of maximal impulse in the mid-axillary line. If you don't get that pad posterior enough, you will not be able to capture that ventricular mass with your transcutaneous pacing. Tachyarrhythmias are beyond the scope of this entire discussion because they're so well covered in your ACLS training, and I'd encourage you to refer back to that, okay? Cardiac arrest rhythms, they have a few of them over here. And I think what they're showing you here is ventricular tachycardia in the bottom left, ventricular fibrillation in the top left, pulseless electrical activity in the top right, and asystole in the bottom right, okay? Again, asystole is not asystole until proven to be such, okay? What does that mean? That means you treat them according to ACLS, but somewhere along the line, after round 1 or round 2 of getting your CPR and your drugs, if you don't have them back, shock it, okay? Because it may be fine VFib, Again, this is my advice. I again point out to you, I'm going off ACLS recommendations when I tell you that. Please do not get yourself in trouble by telling some educator someday that that's the way it really ought to be done. All right. If you have tried to resuscitate your patient, you've done your ACLS stuff, and it is not working, we fall to what are called the H's and T's. They're listed here. Keep an app on your phone. Keep a placard in your EMS rig. Keep something in your medic bag with the H's and T's. I categorically guarantee you, you will not remember them in the middle of trying to resuscitate someone. Okay? The one that is of particular interest today is the pneumothorax, the tension pneumothorax over there on the right, because this is 100% within your power to fix. If you have a patient who has pulseless electrical activity, and when you auscultate them, one lung is breathing and there is nothing on the other side, take a large gauge object, poke it through in the second intercostal space, and re-expand the lung. Leave a cannula behind so that you keep it as an open pneumothorax instead of a tension pneumothorax, okay? All right. High performance CPR, you need to be doing this to the tune of staying alive, which gets you that 100 beats per minute. You need about 2 inches of deep compression with good recoil. That means don't press and slowly release. Press and you're done. Press and you're done. Okay? You need that recoil. That recoil is essential in CPR to creating a really good suction that brings the blood back into the heart. Ventilation rate, do not overventilate the patient. This is the hardest thing to do in a code. You're going to want to, you know, because your adrenaline is flowing and you're losing track of time. It's, okay? You got to go slowly. You only want one of these breaths roughly every 5 to 6 seconds. Otherwise, you're going to drive the patient's CO2 level so low that you're going to screw up their pH balance and you won't be able to get them back. Nowadays, a lot of EMS rigs have automated systems that either do the CPR or measure the quality of your CPR, and they also have special pads that can tell you in combination with your life pack or your Zoll, what have you, whether you're doing good CPR or not. Post-cardiac arrest, a lot of times we cool people. That's beyond the scope of this course, but it does preserve neurologic function for people who might otherwise have lost it. Not quite as enthusiastic about it these days as we used to be, but we still use a lot of it. When not to start CPR. At first I thought this was a joke slide when I first saw this. Yes, if the patient is in multiple pieces, you should probably not try CPR. If the patient is lacking a head, probably not going to be successful. If the body is already decomposing, it's very unlikely that CPR is going to work. They went ahead and put a few more in there for you. Most importantly, though, don't perform CPR if either the patient or their immediate family or their wristband or a giant tattoo on their arm says DNR, although actually I think we may have to talk about that tattoo. I think that's a call to the medical director, right there, Dr. Brandt? Yeah, that one's a call to the medical director. But if the patient has clearly stated do not resuscitate wishes, those need to be respected. Okay? When to stop CPR. There's a bunch of stuff on this screen. I'm going to tell you when to really stop CPR. It's when it's clear that it's not going to work, when you've tried shocking asystole and it still hasn't done anything, and most importantly, when all of the members of your resuscitation team agree that you stop CPR. Okay, sometimes that means you do involve your medical director, but most importantly, everybody who's trying to save that patient's life becomes emotionally invested in them. You don't ever want a member of your team feeling guilty that someone died while they were trying to provide care. So when you're getting ready to stop, you keep doing those compressions and ask your team, you know, we've been at this for 35 minutes, we've had no return of circulation. Is there anybody who wants to continue CPR? Okay, make sure that you have buy-in. If anybody in the team wants to keep going, keep going. Those extra 5 minutes make a difference as to whether that person sleeps well for the next 6 months. Okay, all right, that's it. If the heart rhythm's way too slow, I'll give you a pacemaker. Fantastic. You don't have to worry about pacemaker malfunctions. If you ever want to know about those, I'll be happy to give you guys a lecture on it. And now, get out there, practice these strips, because pattern recognition is the only thing that can really drive this home. Thank you guys. You put up with a lot of me today. I really appreciate it, and I wish you good luck on your tests.